Have a think about how often you touch stuff. Keyboards, doorknobs, buttons in lifts, you name it. And every time you do, you put yourself at risk of bacterial infection. Impetigo is one such infection of the skin. This video will tell you a little bit about what impetigo is, its causes and symptoms, evidence-based approaches to its treatments, and the role that health professionals play.
So, what causes impetigo? Well, it's the result of a bacterial invasion. Staphylococcus aureus is a bacterium that causes both bullous and non-bullous impetigo. Staphylococcus pyogenes can also cause its non-bullous form. There are certain factors that increase your risk of developing the infection. Direct and indirect contact with fomites such as towels, furniture, and utensils encourages the infection's transmission. Warm, humid weather, poor hygiene, and cramped living conditions provide an environment perfect for its development. Being of a young age puts you at greater risk, and scratching causes its spread across the body.
Impetigo can present itself in either a non-bullous or bullous form, as mentioned earlier. 70% of cases are non-bullous. You can see in the images the distinct differences between the two forms. Non-bullous cases appear as a red macule on the skin, turning into a vesicle. The vesicle then bursts and leaves a crusty-looking red mark, similar to a scab. Alongside these evident sores, swollen and tender lymph nodes are also warning signs. The bullous form of impetigo, on the other hand, looks much like blisters. These are very delicate, appearing mostly on the face, but also on the axilla, trunk, limbs, and diaper area. They take longer to rupture than the non-bullous vesicles. When the bullae rupture, a yellow fluid is secreted, leaving behind the borders of the blister and thin, crusty, honey-coloured scabs. Rest assured, if diagnosed, there are all sorts of treatments available, and generally within a matter of weeks the infection is cleared without scarring. For milder cases, a more basic and cheaper approach is to simply leave the affected area to heal itself, bathing the lesion with topical antiseptics. Chlorhexidine, povidone iodine, and hexamidine are all widely used antiseptics to treat. The affected region should clear up within 2 to 3 weeks. Some cases of impetigo are more severe than others. Oral antibiotics can be prescribed by a doctor to treat impetigo. Erythromycin, amoxicillin, clavulanic acid, and cloxacillin are recommended. Generally, oral treatment lasts for 7 days, taking a tablet 1 to 3 times per day, depending on the type and strength. Oral antibiotics are scientifically proven to be more effective in treating impetigo. Speaking practically, if widespread, ingesting a tablet is much simpler than having to bathe a large surface area of skin. Antibiotics have the added advantage of providing resistance against more serious complications of untreated impetigo, such as post-streptococcal glomerulonephritis. Further, the duration of treatment using antibiotics is cut from 2 to 3 weeks to just 1 week. So you might be wondering who can help. If you're suspicious that you have impetigo, your GP would be the first point of contact for diagnosis. They may refer you on to another specialist, they may prescribe you with medications, or they may send a sample of your infection to a microbiologist or pathologist. Dermatologists can be called upon in more serious cases.
And that's a wrap. Hopefully now you know a little more about impetigo, its causes, symptoms, treatment,